Loaiasis, or African eyeworm, is a subcutaneous filariasis caused by Loa. This parasitic infection is limited to the great tropical rainforests and adjacent rubber plantations of Central and Western Africa. It is estimated that up to 13 million people are afflicted with the disease across 11 countries. The prevalence in certain highly endemic areas can surpass 40%. Loaiasis is transmitted by chrysops flies that inhabit the forest canopy. The life cycle of Loa is similar to that of lymphatic filariasis with some exceptions. Specifically, transmission to the human host involves the chrysops fly, and the larvae mature into adult worms over 3 months within the subcutaneous tissues, including the subjunctiva, and adult worms release microfilariae into the bloodstream after 6 to 12 months. These microfilariae subsequently can be found in the urine, cerebral spinal fluid, and sputum of the human host. There are 2 main clinical manifestations of loaiasis. Quote, calabar swelling may develop several months after initial infection. This swelling is a self-limited, localized subcutaneous angioedema of the face and/or extremities associated with pruritus and pain. It is a result of a hypersensitivity reaction to adult parasites and microfilariae. This may last for days to weeks and has a tendency to recur. Subconjunctival migration of adult worms can be directly visualized. During the 10 to 20 minutes required for the mature parasite to traverse the eye, at a rate of up to 1 centimeter per minute, the afflicted experience irritation, pain, edema, and lacrimation. Loaiasis is diagnosed either by directly visualizing adult worms in the subconjunctival and subcutaneous tissues, or detection of microfilariae on peripheral blood smear, as shown in this image. Unlike lymphatic filariasis, loaiasis has a diurnal periodicity between 10 a.m. and 2 p.m. that corresponds with the feeding habits of the chrysops fly. Serologic testing is also available, but its usefulness is limited, again, to screening in travelers who have had no prior exposures. As mentioned earlier in our discussion about treatment of lymphatic filariasis, the drug of choice for loaiasis is diethylcarbamazine, or DEC, for 21 days. However, before treatment is initiated, the microfilarial load must be measured between 10 a.m. and 2 p.m. If the microfilarial load is greater than 2,500 per ml, then albendazole should be initiated prior to DEC to prevent the possibility of encephalitis caused by dying microfilariae in the cerebral spinal fluid. Albendazole only affects adult worms, thereby lowering the microfilarial load without directly destroying the microfilariae. In general, surgical removal of adult worms is unnecessary. Preventative measures against loaiasis focuses on chemoprophylaxis with 300 milligrams of DEC once weekly, which has been shown to be effective for travelers. In contrast, vector control has proven difficult to achieve in endemic areas, but clearing shade vegetation at breeding sites and applying residual insecticides to the mud where the chrysops larvae can be found have been attempted.